Hello guys, this is Dr. Uma. Today I'm going to discuss about Tetralogy of Fallot. In short term, we say TOF. It's a one type of congenital cyanotic heart disease. First, we'll see about the definition. Tetralogy of Fallot is a cyanotic congenital heart disease which is characterized by four anatomical defects that result in decreased pulmonary blood flow and right to left shunt. Okay, so through mnemonic we can learn properly. We can say prove the four defects. Okay, so P denotes the pulmonary stenosis, R denote right ventricular hypertrophy, O denote overriding of aorta, V denote ventricular septal defect. Okay, so when we talk about definition, TOF is the one kind of congenital cyanotic heart disease which is characterized by four anatomical defects. Those are pulmonary stenosis, right ventricular hypertrophy, overriding of aorta, and ventricular septal defect. Right. Etymology: nearly 10% of all congenital heart disease comes under TOF only. So we'll learn more about the four anatomical problem of the heart. Next, I would like to discuss about four classic anatomical defects. The first one is the ventricular septal defect, VSD. There is a hole between right and left ventricle. It develops the blood flow from the right ventricle to the left side ventricle. And the second one is the pulmonary stenosis. This is the narrowed pulmonary wall, otherwise narrowed outflow tract of the right ventricle. Okay, so because this narrow, the blood flow has to move to the lungs will not be proper. Then third one is the overriding of aorta. Overriding. Okay, it means aorta sits over the VSD. I already said that VSD is present. So the aorta is nearly starting very closely in the VSD. So what is happening? Easily the deoxygenated blood, I mean right side heart blood easily moves to the body through the aorta. The fourth condition is right ventricular hypertrophy. There is a thickened right ventricular layers. Okay. Next we move to etiology and risk factors. So actually there is no exact cause of tetralogy of Fallot, but even though it may occur due to any abnormal happening, especially during the first 8 weeks of pregnancy. So if you talk about risk factor, there is a genetic abnormalities is the major reason. Down syndrome trisomy 21 can cause TOF. Then Dye-George syndrome. This is nothing but it's a kind of genetic disorder. It caused by small deletion on chromosome 22. Okay, so it causes not only heart disease, it also causes some poor immune system function, cleft palate, hypocalcemia, and any other distinct facial features problem. Then third problem which comes under genetic abnormalities is Charge syndrome. Charge syndrome is a rare and a complex genetic disorder. It can also cause the gene mutations. Then second factor is the maternal factors. Maternal rubella infection, otherwise diabetes mellitus of the mother, poor nutrition during pregnancy can cause TOF. And environmental exposure like alcohol consumption of the mother during antenatal period, advanced maternal age more than 40 years, exposure to organic solvents. So these are the some of the risk factor, and otherwise we can say etiology of the TOF. This slide explains the pathophysiology of TOF. So I already said that there is a four conditions are present in the heart. The first problem, pulmonary stenosis. Pulmonary stenosis is the narrowing of the pulmonary wall. Okay, so generally pulmonary wall is narrowed, so it will not allow the blood moves freely to the pulmonary artery. If pulmonary artery is not receiving blood, I mean deoxygenated blood freely, then it won't take the blood to the lungs, right? So what is happening? And the second problem, ventricular septal defect, VSD is present. So pulmonary valve is not working or not functioning properly, so all the blood which is receiving from the right atrium, it goes to right ventricle and it's freely moved to the left ventricle. So and the third problem, overriding of the aorta. Once all the blood is moving to the left ventricle, aorta immediately receive the 100% deoxygenated blood and it takes all over the body. So this is what this condition comes under the cyanotic disorder, because aorta is receiving 100% deoxygenated blood, and this deoxygenated blood is moving all over the body. That's why childs get easily cyanosis. Okay. So, and the fourth problem is the right ventricular hypertrophy. This is happening due to increased workload and pressure. Okay, this is the reason right ventricular hypertrophy happens. So one more time explaining. So generally this right atrium receives the deoxygenated blood from the inferior and superior vena cava. Generally it moves to the right ventricle. From the right ventricle it has to go to the pulmonary artery for the purification to the lungs. Because of pulmonary stenosis, it will, the blood will not, deoxygenated blood will not move to the pulmonary artery. It directly moves to the left ventricle with the help of the VST, and aorta also very close to the VST. So aorta receive deoxygenated blood and it takes the blood all over the body. So child feels the cyanosis, and because this three problem, right ventricular hypertrophy happens. Next, I would like to discuss about clinical manifestation. The first one is the cyanosis, bluish discoloration of the skin, lips, and the nail beds due to low oxygen saturation in blood. Okay. Then second one is the respiratory distress. This is the breathing difficulty, rapid breathing, otherwise we can say tachypnea, and poor feeding in infants. Then a very important third signs is the squatting position. Often child sits in squatting position. Look at this picture, baby sits like this. It is like compensatory mechanism to manage. See, because of this problem, what is happening? Deoxygenated blood is moving all over the body. So something heart has to do. Then only the life will be saved, right? So automatically older children, especially older children, okay, they sit squatting position. So what happened in squatting position? Because this squatting position, it increased the pulmonary blood flow. Okay. So because the squatting position, what happens, this aortic blood flow will be reduced. Generally when we squat, what is happening, aorta blood flow will be reduced. So this is what older children does. So because of squatting position, mainly three things happening. One is the increased pulmonary blood flow. Its blood is moving here, and this aorta takes the less blood to the all over the body. So reduced aortic blood flow and increased pulmonary blood flow is happening, and increased venous returns also sustained. Okay, sustained squatting position. So this is what a squatting position is very important. Now then the third, fourth signs and symptoms is, we can say, TET spells. It is the hypercyanotic episodes. So what is happening? Sudden episode of severe cyanosis and irritability and hypoxia triggered by crying and feeding. When the baby is crying, otherwise when the baby gets a feeding, it takes the TET spells. So TET spells is nothing but severe cyanosis attack will be there. Even sometimes the child can go unconscious. It leads to seizure if untreated. Then fifth one is the failure to thrive. So because of when the baby tries to get feed, it takes the TET spells. So of course there is a disturbance in the feeding pattern and the growth related thing. So it causes the failure to thrive. And clubbing. So look at the picture. Clubbing of fingers will look like this. Enlargement of fingertips and toes due to chronic hypoxia over time. Okay, due to chronic hypoxia, enlargement of fingertips and toes happens. These are the very important clinical manifestation of the tetralogy of. Next, diagnostic evaluation. We need to assess the child using both physical examination and other diagnostic test. In the physical examination, we can find out cyanosis, heart murmurs, and respiratory status properly. And with the help of the pulse oximeter, we can find out low oxygen saturation level. If you go for chest X-ray, we can find very typical, changes in the heart. Heart looks like a boot shaped. See, look at this X-ray. So it is looking like boot, right? Then fourth, electrocardiogram. It shows right ventricular hypertrophy and right axis deviation. Then fifth one is the echocardiography. It's a main diagnostic test. It provides the detailed images of all four defects and blood flow patterns. Next, we can go for cardiac catheterization. It's an invasive procedure to measure the pressure and oxygen levels in the heart chambers when it is needed. Okay, we can go for MRI and also CT scan. Then this is about medical management. Medical management, start with the oxygen therapy. Supplemental oxygen should be given to improve the oxygen saturation and reduce cyanosis. Propranolol can be given. It's a beta blocker. It will help to prevent its spells by reducing heart rate and right ventricular outflow obstruction. Then IV fluid should be administered to maintain the adequate hydration. Then morphine can be administered during especially cyanotic spells to reduce anxiety and decrease pulmonary vascular resistance. Then prostaglandin E1 can be used especially in the newborn. It will help to maintain the patency of ductus arteriosus. In my previous videos, I discussed about ductus arteriosus. See, ductus arteriosus should be generally should be closed after the first breath of the baby. This is a normal. But because of TOF, we have to administer, especially for newborn only, okay, we have to administer prostaglandin E1 to maintain the patency. We are just stopping to close, okay, because this problem, lungs is not getting proper blood flow for the oxygenation. At least ductus arteriosus present means what is happening directly. Aorta is giving blood to the pulmonary artery. So through the pulmonary artery, for the oxygenation, the blood can go to the lungs. So this is the main mechanism is working here actually. Then nutrition support should be given. If the complete repair, if the baby has to go, then definitely weight should be increased. So for that, high calorie feeds should be frequently given. And nursing care intervention means some of the special things we need to do, like knee chest position. So if the old children means they sit automatically squatting position, but for the newborn cannot sit in squatting position. So what we are doing here, we are preferring knee chest position. Look at this picture. We have to catch both knees and just take it to the chest of the baby. So this can helpful in systematic vascular resistance and reduced right to left shunt. And oxygen saturation should be monitored, and hydration should be maintained properly, and stress reduction should be done. This is the important nursing intervention for the TOF children. Then very interesting, that surgical management. So there are two types of surgery we can do. One is for temporary surgery, I mean palliative surgery, okay. Anyway, we have to go for permanent surgery. So what is, first of all, what is palliative surgery? We are focusing mainly two types of shunt. We can say shunt. Why means shunt means the connection between something two, okay. So something two vessels. So here first of all we are using block tossing shunt. This is very famous actually, but nowadays everyone is focusing modified block tossing shunt only. So what is block tossing shunt? Actually nothing but look at this picture. Actually this is the block tossing shunt is nothing but here subclavian arteries are taking, and we are just taking cutting the one part, and it is connected to the, what is this? This is the pulmonary artery, okay. So subclavian artery generally arises from the aorta. So one that subclavian artery is, again it is connected to the pulmonary artery. Why we are doing the surgery means, what is the mechanism is happening here? I already said that aorta is actually taking what is it, aorta is taking 100% oxygenated blood to the body, right? So anyway, if the blood has to go to generally to the lungs for the purification, right? So aorta is taking 100% oxygenated blood now through the subclavian artery. Again, we are just connecting to the pulmonary artery. If the pulmonary artery is getting distilled blood, means what is happening? It will go to the lungs for the purification. This is what mechanism we are using. This is called a block tossing shunt. Okay, what is modified block tossing shunt is nothing but instead of connecting directly to the subclavian artery, they are just surgeons are making some kind of connection, like they are using synthetic graft. Okay, this is a synthetic graft. Just we are connecting the subclavian artery and to the pulmonary artery. Especially it is happening in the right side. Okay, so this is about temporary, otherwise palliative surgery for the TOF. Then surgical management for definitive surgery. Okay, so very important point is here. The permanent surgery, definitive surgery has to be done within the first year of life. This is very important. Then 90% survival rate means successive surgery is possible nowadays, and the survival rate of the children are 90%. It's a good result. It gives a good result. So what is happening here? This picture shows the after the surgery how the heart looks like. So first of all, we have to close the VSD. Okay, VSD can be closed by the ventricular septal defect. My previous video shows what is what's the method we are using for the surgical repair of the VSD. You can see that. So patch closure of the ventricular septal defect is we are keeping here, and right ventricular outflow tract patch. So here, because of right ventricular outflow tract patch allows the blood, I mean DXL blood, freely moves towards the pulmonary artery, and it goes for the purification. And here one more thing we need to note it: ligated MBDT shunt. It means nothing but block duct stenching we have done, right? It's a anyway now immediately no one is going for permanent surgery. Mostly surgery will be done temporary first. Actually, once the child's weight is increased, the child is ready for the surgery, within a year we are going for permanent repair. So if suppose a child undergone palliative surgery, it has to be ligated like this. So we are not going to remove the things, just closing. Okay, this is again, if once a permanent surgery is done, this is no need, that's why we closed here. Okay, then prognosis means surgical repair greatly improves the survival, and most children go on to lead normal and active lives with a regular follow-up care. Thank you so much for listening me. If you like this video, please subscribe, share. Thank you.